and welcome to the next edition of webinar. And as you know, today's topic is evaluation of proptosis, which is again a very important aspect in the clinical evaluation and the clinical practice when we get a patient like this. And today's topic is going to be covered by Dr. Swathi Kaliki, who is a consultant in oculoplasty and ocular oncology at L.V. Prasad Eye Institute. And I am sure these are all basic evaluation which is required. Apart from that, the other advanced evaluation which we will be learning today. Without wasting any time, I will invite Dr. Swathi. Welcome, Dr. Swathi.
Thank you. Thank you, Dr. Nayak. First of all, thank you for giving me this opportunity to talk in the webinar. So as already introduced by Dr. Nayak, today's topic is evaluation of proptosis. So I have kept this very basic topic because I think knowing the basics is the most important thing. So we'll go forward with it now. So whenever we say as proptosis, the two terminologies which are used interchangeably are proptosis and exophthalmos. But strictly speaking, proptosis, it refers to prominence of the eyeball, which is secondary to a to an orbital space-occupying lesion. While exophthalmos, we need to restrict that term to the prominent eyes which are secondary to dysthyroid orbitopathy. That is like in the thyroid eye disease, if the proptosis is seen, that is when we use the term exophthalmos. Though most of the time these two terminologies are used interchangeably. And when we define proptosis, I think we should be aware that the definition of proptosis, it varies in different races. When we are talking about the Indian population, the definition of proptosis is if the protrusion is more than 21 millimeters. In the sense that is like, when the measurement is done, if it is 21 millimeter, more than 21 millimeters, that is when you call as proptosis. And this definition, it holds true for the Caucasians and Asians in general. But when we define proptosis for African Americans, who as such have a prominent eyeball, there the definition changes, and here it has to be 24. If it is more than 24 millimeters, then it is called as proptosis. And also if we measure between the two eyes, the asymmetry between the two eyes, if it is more than or equal to 2 millimeters, is what we call as proptosis. Also, when we define the term proptosis, the other thing that we should be aware of is the terminology pseudo-proptosis. So pseudo-proptosis, that means the proptosis is truly not there, but the eye appears to be prominent or proptosed. As you can see the pictures towards the right, where the first picture, the topmost picture, it shows that the patient actually does not have proptosis, but the right eye appears very prominent. That is because the patient has eyelid retraction. Coming to the second picture, here again the left eye, it is proptosed, but here this is not true proptosis. This is because that eye as such is enlarged, which can happen in this child obviously has ophthalmos, but it can happen in like if the patient has staphyloma or high myopia also, they can have prominent eyeballs and thus giving rise to pseudoproptosis. Then again in the third picture you can actually see that the right eye is actually normal in size, it is not proptosed, but it appears proptosed, that is pseudoproptosis, only because the left eye is smaller, that is the patient has phthisis bulbi. And similarly the lower one, the patient has enophthalmos in the right eye, and that is why the left eye is looking prominent, but truly there is no proptosis. So when we say pseudoproptosis, we should keep in mind that it can occur if there is ipsilateral eyelid retraction or ipsilateral macrophthalmos or enlarged eyeball, if there is contralateral ptosis, if there is contralateral enophthalmos, contralateral microphthalmos, or shallow orbit in general, which can occur in craniosynostosis. So when we talk about classification of proptosis, there is no single way that we can classify proptosis. It depends upon various things that we have to consider. So that is, we can classify it based on the etiology, what is causing the proptosis, or the laterality, the direction of the globe displacement, the time of onset of proptosis, the duration of proptosis, and course of proptosis. So we'll go one by one to these. So first, coming to the etiology. Yeah. So etiology, I think it is always nice to put them as whether it is congenital or whether it is because of so the first picture that you see, I'll just get all the pictures on the screen first. So the first picture that you see, it is congenital proptosis. That is, the child is born with proptosis. This can occur, the picture that is shown there is a case of teratoma. So teratoma, which is a congenital condition, this gives rise to proptosis which is present at birth itself. The other causes of congenital proptosis can be that the child has a cystic eyeball, or other causes where it is present at birth. Then second picture, if you see, that's an inflammatory cause of proptosis. So here the inflammation, it is because the child has subperiosteal abscess, and as you can see, there are signs of inflammation on the eyelid where there is rubor, that is redness that is present, and also the globe is pushed out and down as well because of the mass which is sitting there. So it can be inflammatory or infectious cause of proptosis. Then you can have tumors which can be benign tumors or it can be malignant tumors. So the benign tumors, of course, there are various examples of benign tumors. Well, as we go forward, we'll just look into it. So the benign tumors, and the lower one, what you see, it's a malignant tumor where it has caused gross proptosis. So whenever we talk about etiology, it is always better to group them. So that it can be congenital, it can be infectious or inflammatory, it can be because of tumors, it can again be benign, or it can be malignant. Then next, the proptosis can also be classified based on the laterality of presentation. So when we say the laterality of presentation, that means the proptosis can be unilateral or the proptosis can be bilateral. So the unilateral proptosis, when we talk of, again the causes of unilateral proptosis can be multiple. Again, based on where the tumor is located, we can always narrow down our diagnosis. And then whenever we talk of bilateral proptosis, the first and foremost that we have to always think of is the thyroid eye disease. So thyroid eye disease is the most common cause of bilateral proptosis. Of course, the other causes can be because of certain inflammations as well, or more commonly it can be because of the tumors. And the tumors, bilateral proptosis, where the tumors cause bilateral proptosis, is mainly because of the systemic involvement, where it can be metastasis from a systemic disease which can cause bilateral involvement, or it can be benign tumors like lymphoma, where it can again cause bilateral proptosis. The next, based on the direction of globe displacement. This is very important to look. It is very important to know the direction of globe displacement. Based on this, it can be axial proptosis or abaxial proptosis. Axial proptosis, that is where the globe is only pushed forward, and this, it gives us a clue about the diagnosis, because if it is only axial proptosis, that means the lesion is present in the intraconal space, most likely present in the intraconal space, where it can be because of involvement of the optic nerve, like the optic nerve gliomas or meningiomas, or the other common intraconal tumors are the cavernous hemangiomas or the schwannomas, which can be present in the intraconal space. And next is the abaxial proptosis, and also even the thyroid eye disease also, most commonly it causes axial proptosis itself. Then the abaxial proptosis, again it gives very important clue to the diagnosis. Depending on the direction of displacement of the globe, we get a clue of from where the lesion is arising. For example, in the picture that is shown here, we can see that the globe is slightly pushed down and it is pushed out, laterally. So we know that probably the lesion is lying in the medial quadrant. So depending on the quadrant, then we can always narrow down the diagnosis. Like the common one for the superotemporal quadrant are the lacrimal gland tumors, because lacrimal gland is obviously located in the superotemporal quadrant. So if there is any tumor sitting in the superotemporal quadrant, then the globe will be pushed down and inwards. So that gives a clue to us that it is in the lacrimal gland area. Similarly, if the globe is pushed laterally and downwards, then that means that the lesion is arising from the superonasal area. And whenever we think of superonasal quadrant, always we have to think in again we have to see whether it is a child or whether it is an adult. If it is a child, the superonasal quadrant, the most common location of the tumor in the superonasal quadrant is the rhabdomyosarcoma, which we have to keep in mind because this is a malignant tumor. And in adults, the most common cause of a tumor located in the superonasal quadrant is a mucocele, where it can be a ethmoidal mucocele or it can be a frontoethmoidal mucocele. Similarly, if the globe is pushed up and laterally, that means the lesion is sitting somewhere in the inferomedial quadrant. So inferomedial quadrant, here again the common things that can occur are a schwannoma can arise, especially if it is associated with infraorbital nerve, or any lesion that is involving the lacrimal sac area. So this can push the globe upwards and laterally. And then when we come to the other quadrant, that is the inferotemporal quadrant, that means here it can be like any schwannoma that is present there or any such tumors that are present in that quadrant. So the direction of globe displacement is very, very important, which helps us to narrow down the diagnosis. So in general, the axial proptosis indicates tumor in the intraconal space, and abaxial proptosis indicates that the tumor is in the extraconal space. Then next we have to look at what is the time of onset of proptosis. That is whether it is present at birth, that is whether it is congenital or whether it is infantile or whether it is adult onset. That again helps us to narrow down the diagnosis. The first example what you are seeing here is again this is a different case where there is teratoma that is present there. So again if a child is born with proptosis, then the most common causes of those are most commonly they would be tumors itself and not from any other causes. So the most common tumor that can be present where the child is born with proptosis is teratoma, or it can be, as I mentioned earlier, it can be a cystic eyeball as well. And then the infantile onset proptosis that can occur, the most common cause what you are seeing here is a hemangioma, where there is eyelid and orbital component of hemangioma. So only eyelid hemangioma is not going to cause proptosis, but if there is an orbital component to that hemangioma, then the proptosis will occur. So the most common cause of infantile proptosis is the orbital hemangioma. And then the adult onset proptosis. So adult onset proptosis, again it can have various causes to it. One, as I mentioned, it is whenever again you have to correlate always whether it is unilateral and adult onset or bilateral and adult onset. So unilateral and adult onset, again it can be because of variety of tumors that can be present, which again can be intraconal or extraconal, or it can be if it is bilateral, then you have to think of thyroid eye disease or any systemic disease which is causing proptosis. And that, as I'm mentioning, thyroid eye disease causing bilateral proptosis, that does not mean that the thyroid eye disease will not cause unilateral proptosis, because most cases they often start off with unilateral proptosis and subsequently they become bilateral. So the unilateral becoming bilateral is a very common phenomenon for thyroid eye disease, and we should keep it in mind. The next going to about the duration, the classification based on the duration of proptosis. So that is we have to always ask the patient the history, whether it is sudden onset proptosis or whether it is a gradual proptosis. So sudden onset proptosis, always the two things that we have to keep in mind if it is sudden onset proptosis. One is trauma and the second one is infection or the inflammation. So trauma, it can be like the sudden onset of proptosis because of trauma, it can occur if there is retrobulbar hemorrhage, that is one common cause, or it can be trauma induced orbital cellulitis where there is component of both trauma and infection as well. These are the two common causes where there is sudden onset of proptosis. Sometimes the patient can give you a history that the patient has had this history of gradual proptosis, but suddenly it has increased over a few days. That history also sometimes is elicited, which is very commonly seen in lymphangioma. Especially if we are suspecting lymphangioma, if there is a 5 or 6 year old child whose mother complains that the child is having proptosis since birth or since early childhood, and it is gradually increasing and then suddenly it has increased, that indicates that it is lymphangioma, and especially this can happen in association with upper respiratory tract infections. Then second one is then another in between what you have is subacute proptosis. Subacute proptosis is most commonly seen in inflammation, in association with inflammations like the non-specific orbital inflammatory disease. And then third one, or what you can see here, that's the chronic proptosis. That means the patient has been having this for very long time, and this is most commonly seen in benign tumors. Again, for the sudden increase in proptosis, other explanation is always the malignant tumors, but it is not as sudden as that of trauma or infection. So benign tumors, again, usually they slowly grow and there is the proptosis over a period of time. And that again, benign tumors, there are various examples of benign tumors, but at least we should know what are the common benign tumors in children and what are the common benign tumors in adults. So the common benign tumors that you would see in children is most commonly the optic nerve glioma is one common tumor that is seen. And capillary hemangioma is another common tumor that is seen in children. While in adults, the common benign tumors that are seen are the cavernous hemangioma, then the schwannoma that can occur in association with any nerve like the supraorbital nerve or the infraorbital nerve, or sometimes it can be present even in the intraconal space. And the other common benign tumors that can occur in adults are the lacrimal gland tumors. The next, after looking at the duration of proptosis, then of course we have to know about the course. That means whether it is gradually, again it is gradually it is increasing, or if it is stationary, if the patient has had proptosis and it remains the same, it remains stationary, or whether it is gradually increasing day by day. That is one more history which gives us a clue towards the diagnosis. Like for example, the first case, as you can see that the patient has proptosis in the right eye, and there is also fullness that is present in the brow area in the right eye. And this patient gives a history that she's had this proptosis, but it has remained stationary. For the location and the history, we can narrow down the diagnosis that this patient has dermoid cyst. So that is how the course of proptosis again gives us a clue whether it is about the diagnosis. So always taking each and every history is very, very important. While if it is a other benign tumors or malignant tumors, then the patient always gives a history that it is gradually increasing. So in this patient, of course, the left eye is normal. Right eye, there is, as you can see, that there is hyperglobus and there is fullness that is present in the subbrow area as well. So this and the globe is also pushed a little outwards, towards laterally. So this patient actually had a lesion in the medial orbit. So the course of proptosis is again an important criteria that we have to ask. The next, coming to the proper evaluation, so that was about classification of proptosis. Then next, coming to the evaluation of proptosis. So the proper evaluation, always it starts with history. And the history, it not only we should ask about the ocular history, but it is also important to ask about the medical history and the family history. and ocular examination, which we will go in the following order. That is, first talk about the inspection, then the palpation, auscultation, and then the measurement of proptosis. And then of course the systemic examination and the imaging studies. So first, when we talk about the ocular history, we have to always ask about the onset of proptosis. As we have discussed already, the onset of proptosis, again, it can be whether it is sudden onset or whether it is gradual onset of proptosis, the course and the progression of proptosis. As discussed already, the course, whether it is stationary or it is gradually progressing, and the progression as such, whether it is the chronic progression or it is acute increase in proptosis. So these are some of the things that we have to ask. And other associated symptoms of whether the patient has pain, whether there is diplopia, or whether there is any reduction of vision should also be specifically asked. Because if the patient has pain, that means it is either because of infection, or it can be inflammation, or if it is because of tumor, it is because of some perineural invasion which can occur in certain tumors, like especially the lacrimal gland tumor, the adenoid cystic carcinoma of the lacrimal gland. So the history of pain, again, it helps us to give the clue about the diagnosis. Then second, diplopia. I think asking the history of diplopia again is very important, because diplopia, it gives us a clue that either the muscle is affected or it is that the nerve which is supplying the muscle is affected, which is causing diplopia. And so the history of diplopia, again, it gives us a clue that it is something related to the muscle. So that history again becomes important. Then the next is reduction of vision. Now reduction of vision, again, it gives us a clue that either the lesion is involving the optic nerve, which is why there is reduction of vision, or it is some lesion which is kind of compressing the optic nerve, which is causing the reduction of vision. Or sometimes it can happen that the lesion itself is causing retinal or the choroidal changes. Like if it is a very large lesion and it is causing globe indentation, it can cause choroidal folds. Sometimes it can even cause cystoid macular edema or localized retinal detachment. All these things can happen, and that is what can cause reduction of vision. And that is why we should ask all this history. So that was the ocular history. Then next, coming to the medical history, we have to always ask the history, the specific history that needs to be asked. Of course, in general, we always need to ask, if there is any significant medical history in any patient, not just with proptosis, but with any etiology. But in specific, when we are talking about proptosis, the specific history that we need to ask, and I'll tell you why it is important about each of these. So the history that needs to be asked for is if the patient has any history of thyroid disease, if the patient has is a diabetic, if the patient has any history of tuberculosis or history of sarcoidosis or neurofibromatosis, which the patient may sometimes be aware of, or any history of systemic cancer. So these medical history have to be asked for. For example, now the history of thyroid is important because, as I mentioned, the thyroid itself, hyperthyroidism or hypothyroidism can be present in a patient, and the patient presenting with proptosis, you will obviously suspect that the patient has thyroid eye disease, which may be unilateral or bilateral. So that is why that history becomes important. But again, here we have to understand that it's always not necessary that the patient has either hyper or hypothyroidism. Because most of the patients that we see in the clinic, about 80% of the patients are euthyroid. And only 10% of them have hyperthyroidism and 10% of them have hypothyroidism. But still, taking this history can give us a clue. Then second, diabetes. So if there is a 60 or 70-year-old patient walking to your clinic and tells that he is a known diabetic and there is sudden onset of proptosis that he has noted with decrease in vision, then you have to obviously think of the most common orbital infection that occurs in a diabetic patient, that is mucormycosis. So that is why the history of diabetes becomes very important. The next is tuberculosis. So tuberculosis, again, it is important because As such, the tuberculosis, it can cause orbital inflammation and thus cause proptosis. And whenever a systemic disease is present, most of the times it is bilateral, but sometimes it can be unilateral. The most common, the orbital tissue which is affected in the orbit in cases of tuberculosis is lacrimal gland. That is, the lacrimal gland itself can have tuberculous infection, which is what is causing proptosis. The next, sarcoidosis. Sarcoidosis, it can cause bilateral disease, and there can be inflammation in the orbit, and specifically the lacrimal gland may get affected, and most of the times it is bilateral lacrimal gland enlargement with bilateral proptosis. So that is why the history of sarcoidosis again becomes very, very important. The next is neurofibromatosis. Neurofibromatosis, here the proptosis can occur mainly because of three things. One is, it can be because of presence of optic nerve glioma, because that is one of the major diagnostic criteria of neurofibromatosis, which is very commonly seen if a patient has neurofibromatosis. So optic nerve glioma is one. Then second reason why the proptosis can occur is the infiltration of the orbital tissue by neurofibromatosis tissue. So the infiltration of the neurofibromatosis tissue itself can cause proptosis. And the third thing in these patients where the proptosis can occur is, as we know, in neurofibromatosis there can be hypoplasia or absence of the greater wing of sphenoid. So when this happens, so obviously the brain tissue is there is some amount of herniation of this brain tissue into the orbit, and this itself can push the eyeball out and can cause pulsating proptosis, where here the pulsations can be the transmitted CSF pulsations. So these are the three most common causes where proptosis can occur in a patient with neurofibromatosis. And next, of course, the important one is systemic cancer. Systemic cancer, it can cause proptosis either because of metastasis, that is the tumor is obviously spreading to the orbit, which can occur, and most of the times it is bilateral proptosis if it is a systemic cancer. The most common systemic cancer in females where proptosis can occur is breast carcinoma, and the most common cause in males is of course the lung carcinoma. But we also have to remember that the type of breast carcinoma where instead of proptosis you have enophthalmos of the eye is the scirrhous variant. So that is the sclerosing variant of breast carcinoma, where instead of proptosis the patient can have enophthalmos. So that is one more thing that we have to remember. The next is the family history. So family history that is very important to take in a case of proptosis is presence of any ocular disease in the family, or presence of any cancer, or any systemic familial disease. So the ocular disease and the systemic diseases which can cause proptosis, the importance of taking family history in these cases is especially that of thyroid, because if a mother has thyroid problem, it can be transmitted to the child. So that is one thing that we have to remember. And second, of course, it can be neurofibromatosis, which again can be familial, and certain familial diseases which can be the cause of proptosis. And cancer again, that is certain cancers can be hereditary, especially the breast carcinoma or the ovarian carcinoma, they can be hereditary, and that is why taking family history may sometimes give a clue. So that was about the history. Then coming to the proper evaluation of proptosis, that is, first we have to always it always starts with inspection. So the inspection, it starts with the general ocular appearance, inspection of the eyelid, then you have to inspect the lacrimal drainage system, the conjunctiva, cornea, iris, pupil, look for what is the status of ocular motility status, and then important is the fundus examination. So we'll come to each of the importance of each of these. So first is the general ocular appearance. So whenever we talk about inspection in a case of proptosis, about the general ocular appearance, the few things that we have to see for is the facial, if there is any facial asymmetry, if there is any globe displacement, if the patient has pulsating proptosis, if the patient has positional proptosis, what is the color of the lesion if it can be appreciated, and what is the status of the surrounding area. I'll give you examples of each. For example, the facial asymmetry. So you have to note if there is any facial asymmetry, which can happen in certain conditions, for example, neurofibromatosis. So in neurofibromatosis, the patient not only has proptosis because of the three elaborated causes that I've already told you, but the patient can also have eyelid neurofibromatosis, the eyelid or the plexiform neurofibromatosis, and hypertrophy of that area or of that region, giving rise to facial asymmetry. So facial asymmetry you will have to see. And next is the globe displacement. Globe displacement, as I mentioned earlier too, the direction of globe displacement is very, very important, because that gives a clue about from where the lesion is arising. So we have to look for globe displacement and make a note of it. The next is pulsating proptosis. So pulsating proptosis, it requires very careful inspection because it can be easily missed. Pulsating proptosis, it can occur because of the direct pulsations of the tumor itself, which can occur in highly vascular tumors, like certain types of like angiosarcomas it can occur, or highly vascular tumors it can occur, or it can be transmitted pulsations, as I mentioned. So transmitted pulsations, that is especially the transmitted CSF pulsations that can occur if there is absence of the greater wing of sphenoid. In case of neurofibromatosis, then the patient can have pulsating proptosis, or it can sometimes happen in cases of trauma. That is, in cases of trauma where the roof of the orbit has been kind of distorted because of trauma, then it can cause transmitted pulsations and thus cause pulsating proptosis. And another is even caratico-cavernous fistula can have pulsating proptosis. The next important is positional proptosis. So here is an example of positional proptosis. So the second and the third photographs are of the same patient, and this is before the Valsalva maneuver and this is after Valsalva maneuver. So as you can see, before the Valsalva maneuver, the patient actually has enophthalmos on that side, and this is after Valsalva maneuver, where you can see that the patient now actually has proptosis and has swelling in the lower eyelid area. So the positional proptosis, so most of the time these patients who have orbital varices, they come with the complaint that whenever they bend down to do certain work, their eyeball becomes more prominent. And that is it is almost like simulating a Valsalva maneuver, and when the proptosis becomes apparent, as in this case. So the positional proptosis is most commonly seen in orbital varices, and that is how we can narrow down the diagnosis to this one. The next is observing the color. So observing the color is again very important. Sometimes we will be able to see the lesion itself, where you have to see the color of the lesion. That is, if it is a hemangioma, then of course it will be red in color, or here as you can see that it is a orbital varix where it is blue in color, and the other tumor where it can be blue in color is lymphangioma, but the lymphangioma will not cause positional proptosis. So both of them clinically might look the same, but positional proptosis occurs in orbital varices but not in lymphangioma. Then next, looking at the surrounding area. So it is again important to look at surrounding area. So if we see, for example, in this patient, in the first patient, it is a very quiet eye. That means the surrounding area is absolutely normal. But sometimes the surrounding area, it can be if there is redness of that surrounding area, that itself gives you a clue that either the patient has infection or the patient has inflammation. Or if it is red in color, again it may be associated with hemangioma. If it is blue in color, like in this case, it can be a varix, or it can be a lymphangioma, or sometimes it can be just the blood clot that has occurred, especially after trauma. So inspection of the surrounding area again is very important. The next, so after the general appearance, then the next inspection what we have to do is the inspection of the eyelid. So when we inspect the eyelid, the important things that we have to inspect are if the patient has any eyelid retraction, if the patient has eyelid lag, if there is any evidence of ptosis, if there is eyelid edema, or if there is ecchymosis. For example, in the first photograph here, you can see that the patient has eyelid retraction. And the second photograph is of the same patient where the patient has lid lag. That means the upper eyelid is not coming down as much as that of the left upper eyelid is not coming down as much as the right upper lid. So this is what we call as the lid lag. So these are some of the signs of thyroid eye disease. So where if that is the eyelid retraction where it is called the Dalrymple sign, the eyelid lag which is called as the von Graff's sign. So these are certain signs which gives you a clue that the patient actually has thyroid eye disease. And as I mentioned, thyroid eye disease is always not bilateral as seen in this case. So here the right eye appears absolutely normal, while the left eye there is minimal proptosis, and most importantly the patient has lid retraction and lid lag, which tells you that the patient has unilateral involvement because of thyroid eye disease. Then next you have to see if the patient has ptosis. So if the patient has ptosis, it means that either the muscle the paralysis of the levator palpebrae superioris which can cause ptosis is what has occurred, or the nerve supply to the levator palpebrae superioris is affected. That is when the ptosis can occur, and sometimes it can be mechanical ptosis. That means the infiltration of the eyelid muscle and the tissues has occurred, which is causing mechanical ptosis. So these are some of the causes of ptosis, and in these cases with proptosis, and it gives you a clue. And another thing that when we talk of one of the favorite question of examiners is always, in which condition do you see simultaneous involvement of proptosis and ptosis? So proptosis and ptosis simultaneously, it can occur in a patient with thyroid eye disease, because about 10 to 15% of the patients with thyroid eye disease develop myasthenia gravis during the course of disease, where the patient can have simultaneous proptosis and can have simultaneous ptosis. That is when it is, we have to remember that, because both the thyroid eye disease and myasthenia gravis, both of them are autoimmune diseases, and so both of them can occur together. The next we have to look for if the patient has any eyelid edema. So presence of eyelid edema, if the patient has edema on inspection, that means the patient either has infection or inflammation. And other important clue is if the patient has ecchymosis. Like here is an example where the patient has bilateral ecchymosis. If there is clear history of trauma and the patient has ecchymosis, then of course it can be related to the trauma itself, where there is hematoma formation giving rise to this ecchymosis. But if there is clear history that the parents give that the patient has had no trauma and suddenly developed this, then we have to suspect the more dangerous one, that is metastatic neuroblastoma, which gives you a clue that the patient has ecchymosis, and the patient will also have proptosis in these cases because of the metastasis to the orbit. So these are some of the clues that you get with inspection of the eyelid. Moving to the next step, that is inspection of the conjunctiva. So whenever you inspect the conjunctiva, the certain things that you have to see in case of proptosis are if there is presence of any localized hyperemia, if the patient has salmon colored patch in the conjunctiva, or if the patient has dilated episcleral vessels. As you can see in the first picture, here the patient has localized hyperemia which is present in the superior quadrant. Here it gives you a clue. So if the patient has proptosis and localized hyperemia in one particular quadrant, so it indicates that the lesion is present in that quadrant. So that clue you can get. And sometimes the hyperemia might be localized just to the insertion of the recti muscles, which can occur in thyroid eye disease. So that is other thing that we have to know. Then presence of salmon colored patch. So here as you can see there is presence of a salmon. So this patient has proptosis and also has a salmon colored patch in the conjunctiva. So this is a very important clue because this indicates lymphoma. So if the patient also has proptosis, that means the patient has orbital lymphoma with a salmon colored patch, that means also has conjunctival lymphoma. It is called salmon colored obviously because of the color of, it resembles the fish, salmon fish, and that is why it is called salmon colored patch. The next, dilated episcleral vessels. As you can see, this is a typical example of dilated episcleral vessels or what is also called as the corkscrew vessels that are present here. So this is a feature of keratico-cavernous fistula. So if the patient gives a clear history of trauma, maybe just like few days back, or sometimes it can be few years back, and then has this dilated vessels here, the dilated episcleral vessels, we have to always suspect keratico-cavernous fistula, which can be easily detected on CT scan, especially with angiography. So after inspecting the other things, then we have to inspect the cornea. So it is very important to inspect the cornea in cases with proptosis, because obviously they are at risk of developing exposure keratitis. So even if the cornea looks very clear, it is very important to just stain the cornea and check if the patient has superficial punctate keratitis, which sometimes might be limited only to the inferior quadrant. So that can be detected. And other important clue, if for example, if there is a young patient who has peripheral ulcerative keratitis and has proptosis, then you have to think of autoimmune diseases, especially vaginous granulomatosis. So inspection of each of these structures gives a clue to the diagnosis. The next, inspection of the iris. So iris specifically you look for if there is presence of any leash nodules. The leash nodules, that is the hypopigmented patches that can be present in the iris, that gives you a clue that the patient could have neurofibromatosis. Then of course inspecting the pupil is very, very important, because the patient can have relative afferent pupillary defect. Presence of relative afferent pupillary defect in a case with proptosis always indicates that either the lesion is involving the optic nerve or is causing compression of the optic nerve, and that is why it is important to detect that. Has been present for very long time, then the patient can have optic atrophy itself, or the patient can have choroidal folds or localized retinal detachment, or the patient can have cystoid macular edema. So all these changes can occur in the fundus. Then next, after we finish the inspection, so that was about the inspection. Then after inspection comes the palpation. So whenever we see a case of proptosis, these are certain things that we have to do on palpation. That is, first is the retro displacement of the globe. Retro displacement of the globe, it gives you an important clue. So the way that we do this examination is, ask the patient to close the eyes and over the eyelid with the thumb just press on the globe and see if there is any resistance or if there is no resistance. If there is presence of resistance to retro displacement of the globe, that means it indicates that the patient has solid tumor which is causing proptosis. If there is no resistance, that means that the patient has vascular tumor. So each of these tests gives us a clue about the diagnosis. The next, we have to look for pulsation of the globe. So as I mentioned earlier, again pulsation of the globe is something like, we have to, even on inspection it can be picked up, or the palpation, that is just by placing your thumb or finger on the closed eyelid, you can pick up the pulsation of the globe, which can occur in conditions like keratico-cavernous fistula, or if the patient has highly vascular lesion which is causing proptosis, it can cause pulsation of the globe. And thrill, of course, again in keratico-cavernous fistula, the thrill can be present. Then palpation of orbital rim again is very important, because this again gives you a clue. So orbital rim, it can be palpated just by passing index finger along the orbital rim. So if the patient has, while palpation, if the patient has tenderness along the orbital rim, then that means it is either because of infection or it is because of inflammation. If the patient on palpation, you note that the patient has a fossa, that means a smooth curvature that is present, that indicates that the patient has some benign tumor which has been there for very long time, and that is why there is fossa formation, which can occur very commonly in benign lacrimal gland tumors. Sometimes the orbital rim can be very irregular, that means that it is because of malignant tumor. So the palpation of orbital rim, again it helps us to narrow down the diagnosis. And next is the palpation of anterior orbital mass. So if the mass is present in the mid-orbit or the posterior orbit, obviously we cannot palpate the tumor. But if the mass is present in the anterior orbit, that is just behind the septum or in the preseptal area extending beyond the septum, then we can palpate it. So while palpating the anterior orbital mass, the other important thing that we have to remember is to ask the patient to look in the same direction where we are palpating, because this will relax the orbital septum, and that way we can insinuate the fingers and then palpate the orbital mass. And the mass we have to note if only the anterior limit is palpable or whether the posterior limit also is palpable. And then look for if there is any tenderness. So as I mentioned earlier, tenderness means that the patient either has inflammation or infection, which can cause tenderness, or sometimes perineural invasion again can cause tenderness. Then other things that generally we tend to forget is the palpation of the regional lymph nodes and the paranasal sinuses. So regional lymph nodes, at least the preauricular lymph nodes, the submandibular and the anterior cervical lymph nodes should be palpated in all cases of proptosis, because this again can give us a clue. If they are palpable, that means it is either infection, inflammation, or it can be malignant tumors. So the palpation of regional lymph nodes is again important. Then paranasal sinuses, like we can palpate the frontal sinus, maxillary sinus, all those again have to be palpated in all cases of proptosis. So after inspection and palpation, of course in the orbit we don't have anything like percussion, what we do for abdomen examination. So in this, next is auscultation. So the auscultation in case of proptosis becomes important, especially in keratico-cavernous fistula. So as you can see in this patient has proptosis in the left eye, which is very well appreciated here in bird's eye view, where the globe is looking really proptose with dilated episcleral vessels. And when we auscultate, then of course we can hear the gushing sound that can be heard. And also this, when we do auscultation in these cases with proptosis, we should remember that the auscultation is done with the bell of the stethoscope. So we have to use the bell of the stethoscope, ask the patient to close the eyelid, place it on the eyelid and auscultate. And sometimes we can place on the, if it is a high flow lesion, then even placing on the temporal fossa, again you can hear the gushing sound. The next is the most important thing, that's the measurement of proptosis. So this is a classic photograph that is given in your Kansky textbook, where here the gross, that is the Nabs-Zeiger sign. So Nabs-Zeiger sign, that is like, most of the times we don't commonly use this, but at least from your exam point of view and historic point of view, you should know. So Nabs-Zeiger sign is, that is, make the patient sit straight and keep looking straight, and the examiner stands behind the patient and looks down towards the patient from above. And the eye that looks more prominent, like in this case the right eye is looking prominent, the eye that looks more prominent is the eye which has proptosis, which is called as Nabs-Zeiger sign. The other method that can be used for measurement of proptosis, and which is more commonly used by us, where I practice, that's LV Prasad Eye Institute, is that is ask the patient, that is the bird's eye view. That means ask the patient to just extend the neck by about 45 degrees, then the examiner can just sit in front of the patient at the same level, just look at the patient, and the eye that appears more prominent is the one which has proptosis. For example, in this case you can appreciate clearly that the patient has proptosis of the right eye. However, the objective way of measuring proptosis is the objective measurement of proptosis is what we call as exophthalmometry. The two most commonly used exophthalmometers are, one is Hertel's exophthalmometer and second is Lude's exophthalmometer. So I will be showing you a video on how to use the Hertel's exophthalmometer at the end of my talk. So this is the Hertel's exophthalmometer, which I'm sure most of you must be using or at least have seen an Hertel's exophthalmometer. And this is the Lude's exophthalmometer, which is a very simple instrument which can be used again. But we should remember that both the use of Hertel's exophthalmometer and Lute's exophthalmometer, it needs a lateral orbital wall as a reference point. So here the lateral orbital wall should be intact for us to use any of these instruments. And the easiest way, if we do not have, if any of you do not have these exophthalmometers, the easiest way is to use a simple scale, the simple ruler, which is placed at the lateral orbital rim, and then you can measure the distance from the lateral orbital rim to the apex of the cornea. So that can be repeated again on the other side, and you can note the difference between the two eyes. The the advantage of using Hertel's exophthalmometer is that you can get the reading of both the eyes at the same time. But in Lute's exophthalmometer, here you can measure only one eye at a time. Then so this is the video. This I think I'll be playing at the end. Do you want to play now? Okay, I'll play at the end the use of the exophthalmometer. Next we'll continue with, So the other, you should also know what I showed, the Hertel's exophthalmometer and the Lute's exophthalmometers are the most commonly used exophthalmometers. But at least you should know the names of other exophthalmometers like the dual Lute's exophthalmometer, the Nonaxial exophthalmometer, Much exophthalmometer, Coccus plunger, Gormaz plunger, Davinger's prism, and we can also use the radiographic method to measure the proptosis. Other question that is generally asked is, if the patient does not have a lateral orbital rim, which means that we cannot use the Hertel's exophthalmometer, we cannot use the Lute's exophthalmometer, what are the preferred exophthalmometers? So in these cases, these two, that is the Nonaxial exophthalmometer and the Much exophthalmometer, here the reference point is the brow and the cheek. As you can see, this is these are the two, this is the dual Lute's exophthalmometer and this is the Nonaxial exophthalmometer, where here the exophthalmometer is placed this way such that the reference point is the brow and the cheek, and so you can measure the proptosis if the lateral orbital rim is not intact. The other method is the radiographic method. That means a radio opaque lens is placed on the cornea and then a CT is taken, and then you can measure, take a bony reference point and measure the distance between that bony reference point and the radiographic, the radioactive material that is put on the contact lens, what is the distance between the two. So that gives you a measurement of proptosis. So that is one method that can be used if there is any disturbance of the bony landmarks where the most commonly used exophthalmometers are not suitable. Then the other important question is always how do you measure so all these exophthalmometers are great, especially if it is axial proptosis. But for non-axial displacement, how do you measure the proptosis? So for non-axial displacement, you can use what we call as a McCoy facial tri-square, where it tells you how much of forward displacement is there and how much of abaxial displacement is there. Or the other simple method which can be done is by the two ruler method. That means two rulers can be used, one which is placed at the lateral canthus, and then you measure the distance between the lateral canthus till the apex of the cornea, which gives you how much of forward displacement is there. So you do it on one side first and then do it on the second side. Now for example, on right side, if it is say 24 millimeters and on left side it is 21 millimeters, that means 3 millimeters forward displacement is there. And similarly then again you take a fixed bony reference on one point. For example, you can take the Nonaxial and then see how much of displacement is there from that area, how much displacement is there. For example, if on the right side it is about 5 millimeters and on the left side it is about 2 millimeters, so you know that there is 3 millimeters downward displacement or upward displacement depending on the position of the globe. So that is how you can measure the non-axial displacement by simple two ruler method. Then the other test that you should know, what are the other adjunct tests that can be used in these cases with proptosis is trans-illumination, visual acuity and refraction, tonometry, force duction test, diplopia charting, color vision, visual field evaluation. So these are all the adjunct tests that should be done in a case of proptosis. Now trans-illumination is important because when we do trans-illumination, this can of course be done only for anterior orbital lesions. We cannot do trans-illumination if the lesion is present in the mid-orbit or posterior orbit. So trans-illumination, if it is positive, that means it's a cystic lesion. If it is negative, then of course it is a solid lesion. So it gives you a certain clue with this trans-illumination test. Then of course you have to check the visual acuity and refraction. So visual acuity, if again if there is disturbance of visual acuity, then again it could be because of involvement of the optic nerve. Then tonometry, this I think is very important, especially when you are dealing with thyroid eye disease, what we call as the differential intraocular pressure. That means we have to see if what is the intraocular pressure when the patient is looking straight, that is in primary gaze, and then ask the patient to look up and then again measure the intraocular pressure and see what is the difference between the intraocular pressure in straight gaze and in up gaze. If the difference in this intraocular pressure in straight gaze and up gaze is less than 6 millimeters of mercury, then it is not a significant difference. But if the difference in the intraocular pressure is more than 6 millimeters of mercury, then it is significant difference. And this is what we call as the differential intraocular pressure, which is positive if the patient has significant enlargement of the inferior rectus muscle, which is commonly seen in thyroid eye disease, and this is called as a Brayley's sign. The next, the force-duction test. Force-duction test, again it should be done in all cases of proptosis to see if it is a paralytic or a restrictive cause which is causing the proptosis. This I'm sure all of you who do the squint, this is a routine squint, it is used for routine squint testing, so I'm sure all of you must be aware of the technique of force-duction test. The next, in all cases of proptosis, we always have to do diplopia charting. So that is, if the patient has restriction of movement, then the patient will definitely have diplopia. So we have to note if the patient has diplopia in primary gaze or if the patient has diplopia in any certain gaze. That again gives you a clue. Then recording color vision again is very important in all cases of proptosis because the color vision is one of the earliest signs that can be picked up if there is optic nerve involvement. So it should be done in every case, whether if the color vision is normal or if it is disturbed. And last is the visual field examination. Of course, it might not be possible to do visual fields, especially if you are examining the case in your exams. It's not possible to do the visual field evaluation by using Humphrey's perimeter, but you can easily do confrontation test. So the confrontation test can be done in any case in the clinic itself. Then next, so after we do the ocular examination, the next important is to do a good systemic examination. So here are the examples why systemic examination is so important. So as you can see, so this first picture, she was actually a Muslim lady and you can see that she's wearing a burqa, so she had nicely covered her neck and she didn't even tell us anything about if she had any thyroid disease, and so we just to do a systemic examination, we just asked her to take off the burqa, and you can see that obviously her thyroid is so enlarged. So doing the systemic examination, again it gives you a clue to the diagnosis. And here again this child obviously has scapulae spots that you can see the large hyperpigmented lesions that are present here and multiple here as well, and the patient also had leash nodules, everything. So here the cause of proptosis in this child was an optic nerve glioma, which was secondary to neurofibromatosis type 1. So the patient can have features of neurofibromatosis, or there can be features of tuberculosis or sarcoidosis where there can be these granulomas which can be present in the subcutaneous tissue as well, and that is why systemic examination is again important in all cases of proptosis. The next, the imaging studies. Here I am not going into detail about the imaging studies, but just enumerating that the imaging studies, of course, plain radiography, just for historic interest we should definitely know, because most of us, I do not think that we rely only on X-ray. We do either computer tomography, that's a CT, or we do MRI, that's a magnetic resonance imaging. V-scan ultrasonography, sometimes again it is very useful, especially if the proptosis is because of cysticercosis. then here the B-scan ultrasonography, it is very helpful because sometimes we can see the scolex which can be identified by the simple test which is readily available in the clinic. And in cases where we want to see the relation between, to see if there is any bony changes as well in association with the proptosis, computed tomography is the preferred modality. But if you are suspecting a soft tissue lesion, then magnetic resonance imaging is the preferred modality of imaging in these cases with proptosis. Now I'll just play a short video on how to do exophthalmometry before we conclude this session.
In all cases of orbital disorders. It measures the displacement of the eye in relation to the lateral orbital rim. Protrusion of the eye is measured as the distance between the lateral orbital rim and the apex of the cornea. While there are many types and brands of exophthalmometers, the Lutz exophthalmometer and the Hertel's exophthalmometer are used most often. The Lutz exophthalmometer is made of a clear, oblong, plastic graduated rod that is about a centimeter thick. The rod is ruled from 0 to 40 millimeters. The 0 point of the scale is at the tapered end of the rod. This exophthalmometer is placed parallel to a sagittal plane through the eye and roughly parallel to the line of sight when the eyes are in the primary position. In this video, we shall demonstrate the use of a Hertel's prism exophthalmometer, which has a horizontal calibrated bar with carriers on both sides that hold the prisms. While you are in front of the patient, you can view the reflected image of the eye as if you're viewing it from the temporal side. Position the examination seat so that the patient is at your eye level. Illuminate the patient's face with an overhead lamp. Directing the lamp into the patient's eye helps to illuminate the Hertel's prism exophthalmometer, which has a horizontal calibrated bar with carriers on both sides that hold the prisms. While you are in front of the patient, you can view the reflected image of the eye as if you're viewing it from the temporal side. Position the examination seat so that the patient is at your eye level. Illuminate the patient's face with an overhead lamp. Directing the lamp into the patient's eye helps to illuminate the measuring scale of the exophthalmometer and eliminates any error in measurement. Bring the grooved arcs of the Hertel's exophthalmometer to rest on the lateral orbital rim of the patient in line with the canthi. Be sure to use the minimum interlateral canthal distance required to comfortably rest on the lateral orbital rim. Remember to maintain the same bar reading for future exophthalmometry recordings of the patient. Record your reading mentioning the name of the instrument on the left and the crossbar reading on the right. Now, keep your left eye closed and turn your head slightly from side to side to eliminate any parallax error while you view the reflected temporal view of the patient's left eye in the prism. The parallax is eliminated when the two red markings on the two sides of the prism scale coincide with each other. The position of the anterior-most point on the cornea in the millimeter marking graduation is the exophthalmometry reading of that eye. Repeat the same procedure for the other eye of the patient. It is standard procedure to document the reading of the right eye above that of the left eye. The H stands for Hertel's exophthalmometer, 105 is the lateral separation of the exophthalmometer, 18 is the forward position of the corneal apex reading of the right eye, and 19 is the reading of the left eye. Comparative exophthalmometry is the comparison of serial exophthalmometry measurements with previous measurements. As required here, the same examiner uses the same instrument for taking readings on the same patient on all occasions. Relative exophthalmometry helps assess the asymmetry of protrusion between the two eyes of the same person at the same measurement. spirometry is the comparison of exophthalmometry readings to known normal values in the population. The average adult measurement is in the range of 10 to 20 millimeters.
So that was about the evaluation of proptosis, and I hope it benefited you people to understand it.
So far we have received only some comments about the video and audio good, very good audio visual. This is who had commented, Dr. Kalpana from Haridwar and Dr. Shivamoga from Shivnera Eye Hospital. Shankara Eye Hospital. Audio visual okay, Bangalore, Dr. Santosh. So we are just waiting for some questions from the audience so that she can answer the questions if there are any. And I think one thing important which we very clearly highlighted in the Hertel's exophthalmometry, that you have to always also note down the scale reading, because every time when you repeat it has to be same, because the moment you change the scale reading, the reading will change. So that has to be always constant for a particular patient. And some, I think, still are typing some questions. So in the meantime, you want to highlight any other particular things? Something?
Yeah, I think like as has been mentioned in the presentation, so whenever we see a case with proptosis, there are various clues that we can get by simple history taking, which can be like, as simple questions of how, whatever the duration and the progression of proptosis, and just by inspection itself, because it's not necessary that always to arrive at a diagnosis we need an imaging modality. Of course, imaging modality, it helps us, it kind of like, it's an objective way that we can know what is the exact cause of proptosis. But some, in few, maybe at some places where we do not have the provision of this imaging modality readily, we can definitely get a clue about the diagnosis by simple history taking and examination. Can you show? Okay, so we have one question from Dr. Jigar from Vadodara. What is the most common cause of unilateral proptosis in males and in females? So in general, there is no differentiation between males and females in the proptosis, but definitely there is difference between if it is a child or adult. But in general, like if we see a unilateral proptosis in adults, then we always think of first, of course, any proptosis that we see, first we have to always think of thyroid eye disease. And if we have ruled out that it is not thyroid eye disease, then we have to see if it is a quiet eye, like there is no redness, there is nothing, there is no inflammation or anything. If it is a quiet eye, then we have to think that it could be because of a benign tumor. And in general, whenever we see lacrimal gland tumor, most common lacrimal gland tumor that we see is like, the pleomorphic adenomas. They are more common in females in general compared to males. But this is not like, that you can say that the more common cause of unilateral proptosis in females is lacrimal gland tumor. But yes, if we see a lacrimal gland tumor, then it is, in general, that is more common in females. And the other, in general, the most common unilateral proptosis in adults is cavernous hemangioma. That we have to definitely keep in mind. Then there is one more question. Dr. Radhika from Indore, she is asking, can we show any MRI images I would really love to show the images, but on this computer we have uploaded only this presentation, but definitely hopefully we can plan for a class maybe on imaging studies sometime. Maybe any other speaker or whoever is doing it. I'm sure we'll have a session on imaging studies and we can share more images at that time. Dr. Gajraj Nayak from Mysore is asking how to measure eccentric proptosis by two-ruler method. Yeah, so in this, the two-ruler method, it is like you take two scales. One, so the first you just place it at the lateral canthus, and just imagine that this is a scale and we are just placing it like this. And so we take the measurement from the lateral, from the lateral orbital rim, sorry, it's not the lateral canthus, it's the lateral orbital rim. So the measurement from the lateral orbital rim to the apex of the cornea, it gives us how much of forward protrusion is there. And then you place one more horizontal scale taking another bony landmark, say for example Nonaxial. So you just place it like this. So you have one scale here and one scale here. So what is the distance between the horizontal scale and the other scale that you have? That will give you how much of displacement, whether it is upward displacement or downward displacement that is there. So as I mentioned, so if for the right eye, if it is 5 millimeters and the left eye is 2 millimeters, so you know that the displacement in the right eye is 3 millimeters. And the direction, it will depend whether it is upward or downward, it will depend on that. So that is how you use that is what we call as the two-ruler method. Dr. Yogita Chaurasia from Mumbai is asking a question, how to measure proptosis in a case of squint with hurtles. Yeah, so in these cases, when it is not essentially always squint, but sometimes it can also be abaxial proptosis where the cornea the cornea is not exactly in the center. So it is not, you will not get a very accurate measurement by using hurtles. If we have to get accurate measurement, then we have to use other methods like I have already described, we have separate McCoy tri-square and those instruments like that where it can be used for those. But hurtles will give you an approximate measurement. So you can still use hurtles, but it will not be very accurate. Dr. Surekha Bangal from Ahmednagar is asking, can hurtles exophthalmometer be used for non-axial proptosis as shown in the video? So as I mentioned now again, so if you want the accurate measurement, then you have to use different instruments like the McCoy tri-square is an ideal instrument to measure for non-axial proptosis, or you can also measure by the two-ruler method, or you can use the radiographic method to get the accurate measurement. But if any of the, because these are not routinely available, McCoy tri-square, I'm sure many of them will not have it. But hurtles is something that is easily available. So you can always get not an accurate measurement, but you can get a gross measurement by using hurtles exophthalmometer. But ideally, hurtles exophthalmometer is preferable for axial proptosis, and for abaxial proptosis, it gives only a gross measurement.
So then one point I just wanted to ask you, that you said that if it is abaxial, then the corneal apex will not be in the same line.
Yes.
So then that time you will prefer to take it from corneal apex or just the anterior-most part of the eyeball?
Still the anterior-most part of the eyeball in these cases still will be, even if the eyeball is rotated to laterally or in whichever gaze, that will not be very anterior. In some cases, if it is there, then we can always take it to that anterior-most point. But if it is not, because there might be just abaxial proptosis, but the scleral point, prominent point might not be the most prominent point, still it might be the cornea itself. So we will take it to the cornea depending on what the location is.
So whichever is the prominent
anterior,
point,
yes.
So whether it is maybe cornea, edge of the cornea or the
yes.
sclera.
Yes,
okay.
That's correct, yes. Then next, Surekha Bangal again from Ahmednagar is asking how to measure intraocular pressure in upgaze. So in upgaze, again you can use the Goldman tonometer itself, or you can use any other tonometer. You will not get the Myers, it might not be very easy to get the perfect semicircle Myers, but if we have to measure the differential intraocular pressure, what I said, we will have to do it in different gazes. So in these cases, then we will have to do it.
Tono pen might be little better,
because
there
yes.
Because not patient has to be sitting on the straight line.
Yeah.
So any position it can be.
Yes. So even like tonopen or any non-contact tonometers might serve better in these
and even the tonopen area of contact is much smaller.
Yes.
So that way it will be easier for.
Okay.
If you have any tonometer which is either tonopen or as you said
non-contact tonometers can be used. Then Dr. Purvi from Billai is asking, does thyroid proptosis can thyroid proptosis be cured? If so, without surgical intervention. So the proptosis due to thyroid, again, the treatment, it depends on what stage it is, whether it is active stage or whether it is inactive stage. In active stage, we do not do any surgical intervention unless there is optic nerve compression which is occurring. Only in those cases we do, as an emergency, we will have to decompress. Otherwise, generally we do medical treatment in cases of active thyroid eye disease. And then once it becomes inactive, because we have to look at the Rundle's curve whenever we treat the thyroid eye disease. Once it becomes inactive, yes, it can cured in the sense the proptosis can be made less prominent. These can be just by the proper way would be by doing a decompression. That would put the eyeball a little backwards and reduce the proptosis. But sometimes even doing procedures on the eyelids. For example, these thyroid patients, they have their eyeballs look more proptotic, not only because the eyeball is pushed forward, but also because the patients also have eyelid retraction. So just by doing eyelid surgeries to correct the retraction itself can give a better cosmetic outcome in these patients. So without surgical intervention, that, as I said, without surgical intervention, that would be only in active cases we can give them steroids to reduce the activity in them. But the definitive treatment for proptosis as such would require surgical intervention.
But in orbital decompression, one must remember that there is always some amount of motility disturbances subsequent to the surgery. So that patient has to be explained.
Yes, agree with that. Sorry?
No,
okay. Okay. So Dr. Santosh from Bangalore is asking, what is the meaning of dystopia and what is the difference between hyperglobus and hypertopia? So dystopia is if the corneal position, of course, if it is not in the correct position, then of course you call it as dystopia itself. And hyperglobus and hypertopia. So hyperglobus, you would see that this would be used more commonly by the oculoplasty people, where if the eyeball is not in the position, if it's not in the primary gaze, if it is not in the center, if it is pushed upwards, then we would use the term hyperglobus. Hypertopia, this would be used more commonly by the squint people itself, depending on the corneal reflex. Whether the corneal reflex, if it is in the center, or if it is displaced downwards, which means that the position is not correct. So that is what essentially these two terminologies would mean.
I think now there are no more questions. So I thank Dr. Swathi Kaliki for giving such a nice lecture and explaining all basics examinations in case of proptosis. And I'm sure after this, everyone will be a little better off while managing or when you are treating a case of proptosis. Or the first thing to arrive at a diagnosis, and that all these tests will be quite helpful.
Thank you, Dr. Barunai, for inviting me to this, and I really want to appreciate him. It's a wonderful concept. We reach out to so many students, so many people by this webinar, and thank you for making the extra efforts for this.
And also this is available on website in archives. So anyone who has missed out can watch it later on at leisure. So that is, all the previous webinars are available on website. So anything which you miss out, you can watch. But I feel if you watch live, that has got a different perception. and different feeling altogether. Just like watching a movie in the cinema hall and then later on watching a movie on either on TV or you get a CD and start watching. I can bet no one can watch entire movie on a CD without any interruption. But in a movie hall, you are forced to do that because there is nothing else to do and you are committed for that, and plus environment is created. Same way this live webinar is always like those watching movie in a theatre, so that you are concentrating here for the entire course. Also you are asking questions, you are clearing your doubts. So I will recommend that all your friends who are missing out, please try to impress upon them that watch it live. It is always fun and great learning. Thank you, Dr. Swathi, for
Thank you, Dr. Naik. Thank you everyone for listening.